variety of speakers all talking on acute stroke care, and underpinning the session is that we've tried to link it very closely with the stroke specific education framework, and at the end of the session there will be a brief presentation on how you can actually register on the framework and complete your own role profile for wherever you work along the stroke care pathway. Today, speaking first will be Professor Caroline Watkins from the University of Central Lancashire. Also, we have Professor Anne Alexandrov, Dr. Stephanie Jones, Dr. Chris Price, Professor Peter Langhorne, and Dr. Gavin Young. So now I'll hand you over to Professor Watkins.
Okay, so we wanted to try and get lots of people to register with the Stroke Specific Education Framework, and because of some of the developments with the website, this can automatically update your profile if you go and review this session afterwards online at some point. So, like Claire said, Colette will come and tell you about how to do that at the end. So, the Stroke Specific Education Framework has a long history, I guess, but over recent years we've had some fantastic developments with the website and made it much more user-friendly, and we've had a lot of work done on role profiles, so to say what different professions at different gradings, different bands, different levels need to know across the stroke pathway. And we've had lots of different education and training providers that have registered on the website. And all of this is provided free of charge, but it's a great opportunity for you to see what's happening elsewhere in terms of stroke education. So the whole point about it is that we need to find a sort of standardised way of demonstrating the knowledge and skills that people have in order to deliver high quality stroke care. So in 2007, after the National Stroke Strategy, so that's 8 years ago now, and there's been lots and lots of changes in stroke services and lots of thought around the reorganisation of stroke services. And to some extent, because of that, it makes it even more imperative that we're absolutely clear about when people are delivering a part of the service along the stroke pathway, that they do have the right knowledge and skills for the role. So we had UK Forum for Stroke Training, but now that's been incorporated within the UK Stroke Forum remit, so it's all part of the conference, the education and training opportunities, and so all that has been developed. And what we did right at the beginning was to say that really what we were trying to deliver was the stroke pathway, right the way through from prevention to long-term care. And for the stroke strategy, it was divided up into elements of care, as we called them, so that we could say what knowledge and what skills people needed for each of those elements. And we wanted to make sure that it was suitable for everybody, but also free to everybody. And what we were trying to do, and I think we still need to keep drumming home this message, is how do you know? So if somebody commissions a service and says, I want early supported discharge delivered by stroke specialists, how would anyone know that those staff have those specialist skills? So that's why we need to have role profiles to say exactly who should know what and at what level. And we need to make sure then that those targets are achievable so that we have the right training and education opportunities to allow people to update their profiles. So this is the SSEF website, and there's lots of things along there, but if you go in, you can register yourself to get a training profile. And within there are lots of different role profiles for lots of different people. And what you do is you actually go through, and it actually takes you through step by step. As you complete this for defining your skills, it will tell you where you're up to. You can stop at any time, and once you've completed it, then it will also allow you to compare yourself with the National Stroke Profile and tell you what education and training opportunities might be of benefit to you. So you've mapped your knowledge and skills, and it will tell you that if you are saying you are a band 5 nurse, say, the computer will, and you are comparing yourself, you've done your profile, you're comparing it to the national role profile for your banding, and it will say that you match that profile X amount. So it may be that you only match it a bit, or you might match it a lot. So this creates a report, and it tells you where you're at, so you can have a training record. And then it will also tell you, if depending on which course you took, how much of your profile would be updated towards the achieving 100% of what you should know for somebody who's working on the pathway. So if you're an education and training provider, you can use the exact same framework to describe your course. And that means that these two things are comparable. If you describe them in a different way, you can't match the two. And that's the whole beauty of using the framework itself. When you've been on a course, so when you've been to this session today, you can go onto the SSEF website with a review number. You can give it a star rating, you can make some comments, and then that will automatically, because we've already mapped this afternoon session onto the SSEF, it will automatically update that in your role profile. And then when that will then, like being on Amazon or TripAdvisor, it will give people an indication of whether the courses that are registered do what they say on the tin. So are they any good? Are there things that could be better? And that will help you in making choices about courses that you go on in the future. So it's supposed to be useful for individual staff so they can see where they are and where they need to be. It can be useful for training providers so that they could check whether their course content actually reflects what should be in there, and if they're not including something, then they can think about why not. For service managers, it allows them to say, so if staff come to the manager and say, I want to go on a course, the manager says, is it worth it? And you say, well, if I go on the course, I've got a gap in my training profile at the moment for my level, and this course would fill that gap. It's had 4 5-star quality ratings by other people, so it's a good course that would improve my knowledge. How many of you have been on courses where you've come away and you thought, actually, I didn't learn a thing? So you don't want to do that. Time is precious. Time for training is precious, and you don't want to be wasting your time. So you need to be absolutely sure. Commissioners can use it to define which staff need to have what skills for their service. And patient and carers really want to know that they're getting looked after by staff that know what they're doing. So please use the Stroke website. You can go on there, get registered. You can also look at team profiles, so you can think about, so if you're wondering about whether to have Band 3, Band 5, Band 7 staff, you can actually put those things together and have a think about whether you've got the right mixture. You need to have somebody somewhere who's got a critical understanding of things, but you can also have people who have a working knowledge of things to do the day job, but they have to have somebody to go to. So it helps you just think about that. And then also we've got training passports on the way. So that's the web address and the contact details. And this session is being taped, so you'll be able to catch up on any of the information that's there. Okay, thank you very much.
Thank you, Caroline. And I'll hand over to Professor Anne Alexandrov, who's going to talk on anatomy and physiology.
Well, good afternoon. I'm thrilled to be here to talk to you today about how to localize stroke symptoms to brain vascular territories and how to really get a feel for whether this is indeed a stroke that you're looking at in the clinical area. There we go. All right, so to just start with, how many of you are really intimate with the arterial circulation of the brain? All right, a couple of people. Well, let's just kind of look quickly. Here's your two internal carotid arteries. If you take your forearm and lay it up like this and pretend that this is your internal carotid artery, out here is the direct continuation of that, which would be the middle cerebral artery. And if I pull one finger across this way, that becomes the anterior cerebral artery. So just to kind of point to those things on this flat static surface, the MCAs on each side, the ACAs on each side, and then the ACA, you'll notice, continues up this way. So think of that pinky going this way and then continuing up this way along the top of the head. And those are, of course, connected by the one anterior communicating artery. And then there's two posterior communicating arteries. And even though they are called posterior, they are anatomically derived from the internal carotid artery. So they are considered to be part of the anterior circulation of the brain. Now, to look real up close, if you will, at the internal carotid artery, let me see if I can point, yes. All right, so here's the internal carotid artery where it comes up, and notice how you can go this way into the ACA or this way into the MCA, and you have these little lenticulostriate perforating vessels that go around the basal ganglia, around the ventricles, right? Now, you've probably heard the term T occlusion or L occlusion. Have you heard that term? So a T occlusion, imagine if you had a clot that was so big that it was here in the internal carotid and in the internal carotid artery, but extended also into the MCA and the ACA, right? So that would take out considerable area of brain. And the typical L that we think of is ICA over to MCA this way. So those are really large clots when we have them and highly problematic. When we look at the layout of the circulation in the brain, and we'll talk about the posterior shortly, but the anterior circulation, you're really looking at these two big orange areas, the middle cerebral artery, and then the anterior cerebrals, which again are going to wrap up across the top like this. And it's very important to remember that, because as we look at where different functions are located in the brain, you can fairly well guess which artery is involved. So to start with, we're looking at cortical functions. You all are familiar with the cerebral cortex, and in particular, we're looking at the frontal lobe and the parietal lobe to start off this first section. I always like to use something called Brodmann's classification, which is a classification that dates back a long time ago to the early 1900s. But the really nice thing about it is it gives us a numbering system to really understand what different parts of the brain do. And I'm going to present this as I go through the talk, but I'm going to present it in a less anatomically correct fashion that's easier to look at, like this, okay? So we'll be using this as we move forward. Now, what I want to show you first is the area that's responsible for your primary motor function and that primary sensory function. And these are your two homunculi. So we've got voluntary motor and primary sensory, knowing, for example, if someone touches you, where they're touching you, if something is hot and cold, dull or sharp, things like that. So when we think about these motor homunculi, they basically are a graphic representation of how function is distributed in the brain. So you're going to notice that the legs and the hip are up top. Now think about what I said a minute ago. This is your ACA up top, right? So function moving the legs is going to be derived from ACA territory. Everyone got that? Okay. But now look at what comes down the side here, right? You've got hand and then all of your facial stuff, okay? So that means that when we think primarily about just the face, we're thinking mainly about what? Which territory? How quickly they forget. Middle cerebral artery territory, right? And if I have a big ICA clot, I could be knocking out both ACA and MCA, correct? So I could have the whole kit and caboodle, all right? So when we try to draw what that little man could look like, he'd have very big hands like this, a very large face, as you can see, and kind of a tiny body. And this would be the motor homunculus, for example. When we look at sensory, they look a bit different. And in fact, this is from the British Museum, and you can see that the motor homunculus in the blue looks very much like the graphic that we just showed you. But notice the sensory homunculus has got much more distribution present, including the genitals. All right, ACA versus MCA territory then. Remember, up top is ACA, on the sides is MCA. Very good. All right, now language. Language is area 44, so you're going to notice that that's right around here. What was that next to on this area 4? What was right around here? The face, right? Voluntary movement of the face, right? So this is sitting very closely to it, usually on the left-hand side. There are some unusual left-handed people that will have it on the right-hand side of the brain. Every anatomist would like to get a hold of you. But most commonly, we're going to assume, even if you're left-handed, that it's probably on the left MCA territory that we're looking at expressive language. Receptive language is going to sit back farther here in this region over this way. And when we're assessing these things, we of course do things like ask for the patient to name things. I always like to use things on my person. If I don't have an NIH book, I'll say, what are these called? What is this part called? I'm looking for lens, for example. Down here, I'll show them my watch. What is this called? What's this part of the watch called? Things like that to see if they can come up with the specific words. If you have an NIH book, that's very helpful. It shows you pictures that you can point to, of course. Neglect and extinction are going to be things that we think about when we look over into this area. Remember, the sensory lobe is your parietal lobe. And when we're looking at things like double simultaneous stimulation, which is your last item on the NIH stroke scale score, number 11, this is where we would touch the patient simultaneously on 2 different sides with their eyes closed and say, where did I touch you? And they should be able to distinguish that it was both sides as opposed to ignoring one side. They will feel the one side when you do it alone. When you hit it with double simultaneous, if they lose it, that would be your classic neglect syndrome. When we think about the ACA, we also up here think about in the front of the brain here, the location of cognitive function, and it falls into these categories: orientation, memory, insight, judgment, arithmetic, and abstraction. Remember that when you're looking at orientation, you lose orientation first to time. As you get sicker, you lose place, and very rarely will people lose orientation to person unless they have very severe cognitive dysfunction. Same is true for memory. You lose orientation or you lose your short-term memory much quicker than you will lose your long-term memory, all right? And in fact, probably by the time I'm done, you will not remember a single thing that I've said today. So when we localize things to the anterior circulation, we kind of use these rules. If the patient has arm facial numbness and weakness, then it's contralateral or opposite side, middle cerebral artery. Leg numbness and weakness, purely leg, nothing else, contralateral, ACA, arm, face, leg numbness and weakness. Then we start thinking that distal ICA or very proximal MCA that could take all of that out. Does that make sense? Yes, good. Loss of expressive or receptive language, MCA usually left, and neglect is going to be contralateral MCA, and that's usually going to be on the right in most patients. Now let's take, before we close, a look at the posterior circulation. It's going to start here with your two vertebral arteries, one on each side. They give off the posterior inferior cerebella or pica arteries down here. But you'll notice that those two vertebral arteries fuse at the point of the pons to create the one main highway up the back of the brain called the basilar artery. And it gives off a lot of different perforating arteries and some major arteries, such as the anterior inferior cerebellar arteries here. And then up top, the superior cerebellar arteries, and then lastly, the posterior cerebral arteries. So those posterior cerebrals are going to connect to the PCOM-As. Remember that not everyone has a complete circle of Willis. There are a lot of people that are missing sections of the circle of Willis. The most commonly missed sections are one of the ACAs could be gone, one of the PCOMs could be gone, or one of the PCAs is gone. In fact, if you've ever heard the term fetal origin of the PCA, anyone ever hear that term used in practice? A couple of people. Generally, when we see that, that means that the PCOM-A is giving off the PCA because this first piece is missing, all right? So let's start by looking at the occipital lobe. This is your primary visual lobe of the central nervous system. If you have a lesion purely in the occipital lobe, you will have pure visual loss. All right, you're not going to have other things. However, please be aware that if you interfere with the visual pathway, remember your eyes are up here, your occipital lobe's all the way back here. Information has to get all the way from here back to here, right? So if I have a big MCA stroke, could I take some of that out? You betcha, and if you interfere with that, then you could also have visual loss. But how will you know the difference? If it's an MCA stroke, aren't you also going to have motor and sensory loss of the arm, potentially the leg, the face, right? Potentially aphasias, potentially some neglect, all right? So these are how we're going to think differently about that. Now, when we think about this, we're talking about the green sections back here being PCA territory. And just to quickly refresh your memory about how far all that information has to get from the brain, it's a pretty long distance traveling all the way back there to the visual cortex for things to be interpreted. Lots of different rules for localizing vision. Remember that if you have a patient that cannot participate in the exam, then you have to confront. What do I mean by that? Surprise and look to see, do they blink, right? That's about all that you can do. If they don't blink, then you have to, of course, question yourself, did I do that appropriately? If they do blink, you have to assume vision is intact. If you have visual loss in just one eye, it has to be retinal or optic nerve. It's both eyes. It has to be at the chiasm or further back along that visual track. And a harmonious hemianopia is always beyond the chiasm. And like we said, if you have a large MCA territory infarct, you can certainly create a harmonious hemianopia. And diplopia, if you ever see that in an exam, is not an occipital lobe finding, it's a brainstem finding. Cortical blindness can certainly occur, and again, if you're familiar with the vascular territory here, imagine placing a clot right up here at the tippy top. Notice how I could be knocking off those two PCAs without any flow. You know, when you think about the PCOM-A, certainly it is there to provide collateral flow, but it is not the most dynamic of flow places. And so, therefore, just because you've got a complete circle does not mean you're going to avoid an infarct. Cerebellar stroke, vascular territory is going to be your basilar artery, the branches of it as well. Normal physiology, remember, for cerebellar is fine motor function, equilibrium, balance, and things like that. When we test the cerebellum, we ask patients to do things that we would ask a patient if we pulled them up over like a policeman does for driving while intoxicated, right? So we remember their motor function is intact with a cerebellar performance, right? So they have the strength, they don't have the finesse, so to speak, right? And so if you ask them to close their eyes and touch their nose, you might end up with something a little suboptimal, if you will. And these are just some of the things that we can do to test this. Brainstem, lastly, vascular distribution, branches of the basilar artery and the cerebellar arteries. Note that because you've got such a busy thing going on back here in such a small, compact area, it is very common that if you knock out the cerebellum, you may also knock out a piece of the brainstem and vice versa. So it's not unusual to have both. And of course, the brainstem does lots and lots of things that we don't have time to get into in detail. Double vision, if you do see it in a patient, is the most common subjective complaint that we have for patients with ocular motor system problems. And it's basically a lack of visual fusion. I had a patient recently on the mobile stroke unit, 36-year-old with an acute basilar thrombosis, and one of the major tip-offs to me was she kept going like this, squeezing her eyes closed, shaking her head, and looking at me like this. She was also anarthric, and so she couldn't really articulate anything that she wanted to say. But I said to her, "Are you seeing double?" She said, "Yes." I said, "Good enough for me," and I pushed the TPA. All right, so the other thing to think about in the brainstem, and again, we don't have a lot of time to get into all of this, but it's important to remember that in lower brainstem strokes, you can have crossed symptoms, so that the face can be down on one side and the arm and leg can be down on the other side. All right? Does that make sense? Okay, so that can happen in the lower brainstem. But the basilar artery thrombosis, unfortunately, is the most frequently missed stroke that's out there. It's very complex. It has numerous presentations that can be anything from something that looks like an MCA territory infarct with loss of motor and sensory function, to hiccups, vertigo, shivering, to very severe presentations, as you can see on this list right here. So not all basilar artery thromboses start as very severe events, but they certainly can become one if we don't act very quickly to resolve these. So in closing then, to differentiate rules for sensory and motor functions, hemisensory, in other words, half of the body sensory or hemimotor loss, that's coextensive, all on the same side, involving the face and the extremities, indicates that the lesion has to be in the cortex, the thalamus, or the upper brainstem. A cardinal sign of a brainstem stroke is bilaterality, okay, so that you have ipsilateral loss on one side for the cranial nerve deficit affecting the face, and then contralateral extremity weakness and or sensory loss. Uncommon findings, especially in a non-hemorrhagic stroke, such as sudden loss of consciousness, for example, or things like auditory loss. Even though the temporal lobe certainly plays a big role in auditory function, the brainstem should always be your first suspected area with sudden auditory loss. This is something that we would always think posterior circulation. So let's test you. A 56-year-old man with sudden onset right arm and leg weakness and left facial droop. Where could the stroke possibly be? Or is it a stroke? Certainly the brainstem, right. A 48-year-old woman with dense, can't move it at all, left arm and leg weakness and numbness with a totally intact symmetric face. Is this maybe a mimic? Yeah, okay. Remember where the face sat next to the hand on the motor homunculus. Is it possible that you could have saved the face and knocked out everything else? Probably not. In fact, sadly, for those of us that are women in the room, we hold the record for being the top stroke mimickers in the world. It almost always affects our non-dominant hand or side. And one of the classic findings is that the face is fully intact, but all this is out. These are the patients that if you take their hand and they say, no, I can't move it, and they drop it, well, take it and put it right over their face and see if they'll let them hit themselves in the face. They usually will not. Instead, you'll see them go like this. And so it becomes a very, very interesting presentation. 33-year-old woman with diplopia, right arm, leg, and facial weakness. Could be a migraine. Absolutely. What would happen if I gave this patient TPA because I didn't have access to the MRI to clarify whether this was indeed a stroke? What's her risk for bleeding? Extremely low. Treat her anyway if in doubt. But this would likely be also a brainstem stroke. And 67-year-old man with right arm and facial weakness and loss of expressive language. MCA on which side? Left. Very nice. So there is a little localization card that you can order for yourself that's available through the Association of Neurovascular Clinicians. You can get it at anvc.org. It fits right into your pocket. It's a tiny little card. Very, very helpful. And I thought I'd close with this. This is how we felt in the United States immediately after our election. This is what our newspaper said in Memphis that next morning. And indeed, we've discovered that this isn't what we meant when we said orange is the new black. Thank you so very much for your attention. And that's my mobile stroke unit.
Follow Dan. Good afternoon, everybody. I'm Stephanie Jones. I'm a Senior Research Fellow within the Stroke Research Unit in the University of Central Lancashire in Preston. And my research interests really are around improving recognition of stroke amongst the public and also improving recognition of stroke amongst the emergency medical services. So a lot of what I'm going to focus on this afternoon will refer to the pre-hospital part of the pathway. So this slide is 10 years old now. Many of you will be familiar with it, but I like it. It kind of represents for me a point in time where we really start to think of stroke as a medical emergency, and symptoms and mechanisms are starting to gear up to respond and to support stroke as a medical emergency. And the graph just shows that as time ticks on after the onset of stroke symptoms, then the number of patients that we need to treat increases in order to get a good outcome. I think the phrase at the bottom about the 1.9 million neurons that are lost every minute, I think as well provided some kind of visual representation and maybe something more tangible for people in terms of acting more quickly. So I suppose we're looking now within stroke that we've got a number of key drivers for change that have really improved stroke care across the pathway. But this afternoon I'm going to focus on recommendations and evidence from the RCP and the NICE guidelines, and also from the NICE quality standards briefing paper. So the conference is quite timely, and I'm sure there's going to be lots of presentations over the coming days that include recommendations, both new and updated, and the evidence underpinning that from the National Clinical Guideline for Stroke. But I think it's worth highlighting that the guidelines have highlighted that there's still a paucity of research relating to the pre-hospital part of the pathway. And I know some of us here have been involved within pre-hospital stroke research, and it can be a challenging environment in which to undertake research, but I'd kind of challenge you to embrace that and do become involved within pre-hospital stroke research if you can. The emergency services are always keen to be involved. So the public awareness campaign around the FAST we've all seen, and the first FAST campaign came out in 2009. So you think of the time as brain slide in 2006, things are really moving apace by 2009, and we're trying to get across the message not only to health professionals but also to the public that stroke is a medical emergency. And I think now we're at the point where we're also trying to encourage the public to be aware that they need to access specialist stroke treatment at the earliest opportunity, and also to be aware of treatments that may be available. So within this current edition of the clinical guidelines, the recommendation around public awareness is that we should be targeting public awareness campaigns at those most at risk. And I think that's really emerged from the evidence over the past few years. And unfortunately, those who are at highest risk of stroke often have the lowest levels of public awareness of stroke. So I think it's everyone's business to take every opportunity to raise awareness of stroke symptoms and the emergency response that's required, particularly in high-risk groups, which may include older people, those with hypertension, AF, who've had a previous stroke or TIA, and those with diabetes. So we're relying on the public to recognise symptoms and to contact the emergency services without delay. But unlike other conditions, the majority of people who contact the emergency services for stroke are a bystander rather than the patient themselves. And there's been the STAR study recently carried out in Sheffield, led by Dr. Jessica Redgrave, and they found that the majority of bystanders are usually family members, so a son or daughter, and that bystanders intervene usually because the patient is unable to contact the emergency services for themselves, but up to a quarter will actually refuse to seek any help for a number of reasons, quite commonly because they don't realise that stroke symptoms are serious and require an emergency response, or some may just be in denial or don't want the fuss of contacting the emergency services. So bystanders are more likely to contact the EMS, whereas patients are more likely to contact the GP in the first instance. And within the STAR study, a bystander calling the emergency services was an independent predictor of patients arriving on the stroke unit within 4 hours. So I think thinking back to the recommendations within the guidelines about targeting patients at high risk, then there's something to be said for targeting the families of those patients who are at high risk. So we're hoping that a bystander has recognised the symptoms and they've contacted the emergency services. And the call handler's got the tough job of trying to recognise stroke over the phone with the limited amount of information that they have. And as part of an NIHR-funded programme of research called ESCORT, we developed stroke-specific training for call handlers and rolled that out within North West Ambulance Service. And we used an interrupted time series analysis over a period of 18 months and looked at recognition of stroke by call handlers before rollout of the training, during implementation and afterwards. So the stroke training included lots of things around different types of stroke and stroke symptoms, but the majority of the training was around the words that the public use to describe symptoms and the words that they also use to describe other important things, such as conscious level. So the current guidelines suggest that call handlers and primary care receptionists should be trained to recognise the symptoms of stroke, that they are an emergency, and that the patient requires transfer to a hyperacute stroke unit. And within the ESCORT study, before rollout of the training, recognition of strokes for 59%, and this rose to 79% during implementation, and then dropped off slightly to 76%. But I think it does show that with stroke-specific training, we can improve recognition of stroke at that very early stage, and it's about getting patients into the stroke pathway as early as possible. So we move on to the ambulance service, and the current guidelines say about using a validated screening tool such as the FAST. And the FAST is pretty good at identifying stroke patients when used by ambulance clinicians, and depending which papers you look at, sensitivity of the FAST ranges from 79 to 97%. But we know that the FAST doesn't pick up all stroke patients, and studies have shown that around 38% of patients, particularly those with posterior stroke symptoms, may be missed by the FAST. There's also been some research in the United States to say that door-to-needle times are longer for patients with posterior stroke, so around 20 minutes longer, and also time to assessment by a neurologist was 60 minutes longer. And I think this has been picked up by FAST by NICE in the quality standards briefing paper published last year. And there's been some suggestions that paramedics and technicians should receive some additional training about how to identify patients who are non-FAST positive and the appropriate techniques that we should be using to identify those patients. But at present, there's no consensus about which tools should be used to identify non-FAST positive patients, although there is an emphasis on delivering the same level of care. So we've had the call handler hopefully dispatch the call correctly, and the ambulance crew arrive on scene, and they'll be assessing airways, breathing, circulation and disability and correcting as appropriate, and then recording blood glucose, blood pressure and GCS, and also assessing blood glucose and blood pressure to rule out any stroke mimics. They may consider a 12-lead ECG if it's not going to delay transfer to hospital, and IV access if that's essential. So then they'll carry out the FAST, and I think the time element is really important here. So having a clearly documented onset time is something that's been poorly recorded, not just within the pre-hospital part of the pathway, but also within hospital records as well. And there's lots of evidence from around the world, but I've used this reference in particular because it's a study from the West Midlands, which says that patients that have clear onset times who are FAST positive and who are transferred with a pre-alert receive prompt brain imagery and treatment, so not unsurprising. So within the current recommendations, research has established that current licensed indications for alteplase treatment should be widened, and the research evidence underpinning this comes from IST3, the updated Cochrane thrombolysis review, and from patient meta-analysis. But I think the key message that's coming across from all those pieces of evidence is how critical it is that treatment is started as quickly as possible after the onset of stroke, and that treatment within 3 hours is more effective at reducing death or disability. There is a section within the guidelines that's called What's New, so do have a look at that section in particular. And this is, for me, one of the exciting recommendations in terms of patients with suspected stroke should receive brain imaging at most within 1 hour of arrival. And in the previous recommendations, this was suggested as being within 12 hours. So I think it really shows that we're still trying to improve systems and we're putting mechanisms and staff in place to respond to stroke as a medical emergency. So the next slide before I finish, I'm not usually one to embrace social media, but this is a message that was posted on Facebook, and it's been really widely shared and commented upon. It's not somebody that I know, but I contacted Alison to ask if I could share her post with you. And I think it really nicely sums up the importance of stroke as a medical emergency and really why stroke care is such a team effort. So I'll give you a couple of minutes just to read it. So it's just to say that Alison's father is making a good recovery, and fingers crossed that continues. So take-home messages from me are that the stroke pathway begins before the patient arrives at hospital. I think it's easy to forget that quite a lot happens before the patient comes through the doors. That recognition of suspected stroke is challenging within the pre-hospital part of the pathway and also for particular stroke patients. There's currently no consensus on optimal pre-hospital assessment tools for patients who are non-FAST positive. Within the new guidelines, there's lots of recommendations and evidence, so please do take the time to have a look at those, and I'm sure we'll hear lots about that in the coming days. And I think as we go forward, there's lots of evidence and guidance that is still sending a clear message that time is brain. Thank you very much. I think that lots of people are aware of the fast symptoms. They've seen the campaign, and they may be able to recognise 1 or 2 or 3 of the symptoms. But I think there is a huge difference between being aware of the symptoms, recognising the seriousness of those symptoms, and recognising that they are a stroke. So I think having stroke awareness and knowledge is one thing, recognising a stroke as a medical emergency and seeking help for it is something different.
Mm-hmm. Do you think there's particular people that delay, wait to check with their relatives? Or
I think older people in particular. We've interviewed lots of people who've had previous strokes or TIAs, and worryingly, they're no more likely to seek help quickly. I think it's quite complex in terms of why people do or don't seek help. But I think it's interesting, particularly from the STAR study, and there's research evidence from Australia and from our ESCORT study, that families have a key role to play in recognising symptoms in a family member and seeking help on their behalf.
okay, all right. Thank you very much.
Yeah, I was just going to add 2 things. In the States, there's no funding available for any of these campaigns, which has always kind of blown me away. And one of the things that they've done for us is made it a requirement that if you're going to be a stroke center, designated as a stroke center, then you must spend time in the community doing these endeavors as part of your charge. And so you will see a lot of education given to lay people. Beauty shops are a big place. Churches, for example, are another big place that are targeted, especially the African American population, which has a 300% higher risk than whites in the United States. But the other thing I was just going to mention is our pilot study supporting the TEST trial, which is targeted education and stroke trial using test-enhanced learning, has shown that patients, even if you do the best possible job teaching them about symptoms for stroke, for example, about their medications, about use of emergency systems, all of this, that you're likely that at discharge only 25% of that is retained. But when you use test-enhanced learning and they know that they have to take a test before they leave, suddenly that goes up to almost 100%. So we're actually now doing a randomized control trial looking at whether test-enhanced learning should be kind of the standard for how to move forward in educating people.
Got time for a quick question?
Yeah, hi. It's not a question, actually. It's more of an observation that I noticed. I don't know whether it's reflected across the country. But I think there's 2 areas whereby we're not very good at recognising stroke or not very good at dealing with stroke. And one of those, unfortunately, I think is A&E. I think they tend to say, we'll leave it to the stroke team. Again, I don't know whether that's a reflection. But also, as well, is inpatient strokes. I think as a profession, as nurses, we're pretty poor at observing inpatient strokes, basically, as well.
Yes, yes, and I agree with that. And I think we did a paper, well, it must be, God, I dread to think, but it must be about 15 or 20 years ago, we did a paper because we looked at inpatient strokes and how long it had taken people to notice that a patient had had a stroke on the ward. And you really think if you were in hospital at the time that you would get very fast treatment, but it wasn't the case at all. So, yeah, people need to get better at that. I think raising awareness in our colleagues is definitely something we have to do.
Okay, we'll move on to the next presentation, which is by Dr. Chris Price, and it's on neurological and physiological assessment.
Thank you very much. So I think people must have heard I was up next. They disappeared. So, actually, just if I can just continue whilst I've got the mic. I think about 5% of stroke is inpatient stroke. That's what we found. And of course, they're a challenging group. They're not often suitable for thrombolysis because of the reasons why they're actually in hospital in the first place. So the treatment rates for thrombolysis are lower. And they're a complicated group because of all the reasons why they weren't suspected stroke in the first place, but it's definitely something that does need to improve. So, right, I shall stick to the script and get back to what I was meant to talk about. Right, so neurological and physiological assessment, monitoring and management, very big topic, something that actually I could talk about for quite a long time, but I've got 15 minutes apparently. So what I'm going to do is break it down into national clinical guidelines. As Steph's already mentioned, there's going to be a lot of that over the next 2 days. Neurological assessment, physiological assessment, and what happens after thrombolysis. So, which came first? The challenge in this area is that neurological and physiological changes after stroke are very related. So, which came first, the neurological change, or was it the physiological chicken? And this means that it's really hard to unpick sometimes when a patient is deteriorating. Is this a pure neurological deterioration that you might expect from the stroke that they seem to have been having in the first place? Is it a complication of that? Is it a neurological one? Or is it a physiological change? And the more severe the stroke, the more physiological disturbance can be, which leads to more neurological deterioration, which leads to more severe stroke, and so on it goes. Consequently, this is quite a hard area for research to have dealt with. And variations of the amount of neurological deterioration or changes in observations after stroke vary a lot, but it's thought about 10-15% of admissions to acute stroke units will deteriorate neurologically over the next 48 hours. And if people want to remember one thing from what I say in the next 10 minutes, it's really, if you've got a patient with neurological deterioration, is it explainable by a modifiable physiological change? It's important to look at their blood pressure, their temperature, oxygen saturations. It's simply they've got an early aspiration. Have they got something which can be treated with antibiotics? Have they had a PE? Do they need oxygen fluids? Can that actually then improve their neurology again, rather than assuming it's just a neurological change and part of the course? So what do national clinical guidelines say? Well, they recommend that patients admitted to our hyperacute stroke unit, where staff who can do monitoring are trained and have the equipment. And not surprisingly, they say that all of these elements of the clinical stage should be monitored closely. The brackets, by the way, are put in just to remind me that I'm not going to talk to you about those. I'm going to talk to the things that aren't in brackets. Okay, so I'll do with each of those next. So let's first of all talk about sort of genuine or primary neurological deterioration, patients who get worse because of the actual stroke. Let's remember that stroke is a condition of the brain, and these things listed on the right are changes that can occur in the brain itself that lead to the patient deteriorating neurologically and may require re-imaging and medical review. So progressive infarction is a bit of an old-fashioned term, but basically it means that the stroke that the person was originally having is getting worse. And actually, strangely, we may see more of this as patients come in more quickly. We're actually seeing people deteriorate more. Well, actually, they used to do that at home before they came in. It's just they're now doing it on the ward. So we're actually seeing more of this, and it's a little frustrating because we give them thrombolysis, we try and do things to maintain their condition, and they still get worse. And really it's just because, particularly with ischemic stroke, it's because of the collateral supply to the ischemic area isn't good enough. And you know, in this case, some of these was a scan, that started off like this, and then develops later on into a full left middle cerebral territory infarct. And that would be obvious by deterioration in face, arms, speech, all the things that we heard about half an hour ago that are related to that vascular distribution. Now, of course, some of those patients will actually develop very large areas of infarction. The brain swells up. They'll get cerebral edema. As a consequence, that compresses the brain and gets inside the skull. They will then start to get drowsy. They'll then start to become unconscious, may actually die as a result. And some of them will go off and have surgery to relieve that pressure by a hemicraniectomy. And of course, these patients, they may have a deterioration in face, arms, speech, etc., but predominantly they're getting drowsy. They're becoming unconscious and harder to wake up. And that's quite a hard thing to watch over a shift. It's very important that if you've got a gut feeling these people are deteriorating, then you do keep checking on them, try and record the level of awareness, which I'll come back to in a second. Cerebellar stroke. So, you know, this one is particularly, people with stroke and cerebellum, particularly prone to becoming drowsy and confused and then unconscious and potentially dying because of the expansion of the hematoma or the infarction area in the cerebellum hasn't got much room to go. There's much less area in the skull at that point for the expansion to be accommodated, and consequently it takes less expansion of the hemorrhage or the infarct before they actually become drowsy, confused, and then slip into unconsciousness. Actually, again, these patients can go off and have a decompression of this area, which can be life-saving, and actually then go on and make a very good recovery. Basilar artery occlusion we just heard about. Here's a occluded basilar artery here on CT scan, and again, these patients may actually be fluctuating to begin with, at times may be fairly alert, but then fluctuate, deteriorate, and when they get to this stage, are very difficult to help. Large area infarction, brainstem, occipital areas as well. And again, spotting this group early on is very, very important because they may be suitable for a removal of that occluding thrombus by thrombectomy later on than thrombus elsewhere in the circulation. What about hemorrhage? Well, these patients well deteriorated well due to expansion of the hemorrhage. Here's a patient deteriorated, initial blob there on the scan, bright white blob larger there on the second scan after they deteriorated. The hemorrhage is ruptured, it's larger. Again, some of these patients will go for decompression, but actually the evidence for neurosurgery is not very good at all. Again, they'll be picked up really by the fact that they deteriorate with their conscious level once that starts to happen. And hemorrhage may result in hydrocephalus from hemorrhage going through into the interventricular space, occluding the CSF drainage and creating hydrocephalus, these large ventricles here. Sorry, I keep hitting the wrong button. These large ventricles here and here. And again, going and having a shunt put in, relieving of that pressure, may actually be life-saving. Some of these patients may want to make a very good recovery, despite the fact they had quite severe hydrocephalus come on acutely. So you can see that actually quite a lot of these situations can actually be picked up by simply looking at conscious level, by patients becoming less alert, confused, drowsy, and then difficult to wake up. So many of us are sort of obliged now to use just standard early warning scores in terms of monitoring patients on the ward, which include the AVPU there. And actually, in some ways, that's not bad for picking up some deteriorations. It's not very sensitive, but once people have moved a grade on here, then that should really be taken very seriously. And the patient should have medical review, sort of CT scan. And of course, there's other observations done to see whether or not there's actually a non-neurological cause. GCS here, if you look at the eye-opening part of the GCS, it's really pretty much the same as the AVPU. And actually, personally, not a great fan of the GCS because the verbal responsiveness, the moving of the arm after stroke, it causes a lot of confusion about what really their conscious level is. The eye opening is much better. Now, of course, we do want to pick up more subtle degrees of deterioration and fluctuation, so there are ways of doing that. Of course, probably the best known is the NIH score, National Institute for Health Stroke Scale. Obviously, it's a detailed score, a complicated one to do for lots of monitoring. Who's done the training for this? Put your hand up if you've done the training for this. Ah, great, excellent. So, but you wouldn't particularly want to be doing it every 15 minutes, would you? There are shorter versions, and a score of plus or minus 4 indicates really a significant change. There are short versions, an 8 version, an 8-point version, a 5-point version. And really, I think what's important is that units agree which version they're going to use. Everyone's trained in that, and they apply it routinely, and people know what it means when they talk to each other in those terms. There are even much simpler versions like this one over there. So physiological observations. Start with blood pressure. We know blood pressure is very common in acute stroke. This is just data from the first international stroke trial showing how common it was. And high blood pressure is linked to poor outcome. So the question then is, well, should we treat it? It's more complicated than that. And the recommendations are that people who are already on treatment for hypertension should continue that as soon as their condition allows. We shouldn't stop it. We should carry it on. And patients with acute ischemic stroke shouldn't routinely receive blood pressure treatment acutely that's new unless they meet one of these situations. And if you see, this one's obviously to in order to allow people to have treatment with thrombolysis, but the other ones really are not common situations, and we shouldn't routinely be lowering blood pressure in acute ischemic stroke on the basis of trial evidence. Having said that, it does depend how early, and this is just from the Cochrane review of interventions to deliberately alter blood pressure. Very briefly, these numbers over here, the lower number indicates a possible effect of benefit from the patient. You see that treating patients very early on pre-hospital or within 6 hours may actually have a benefit for patients if their blood pressure is lowered, but this is all still not enough to change our practice, certainly for ischemic stroke. After 6 hours, there's actually one trial here that suggests it may be harmful to treat blood pressure in acute ischemic stroke. But this is different for hemorrhage. The Interact True trial here, that was about hemorrhage, and consequently, the guidelines say that in patients with primary and cerebral hemorrhage present with 6 hours of onset, with systolic blood pressure under 115 should be treated urgently with a locally agreed protocol to get that blood pressure down lower, with some exclusions. And that's because when it's a hemorrhage, that rupture of the hematoma can be reduced by reducing the blood pressure. And the main evidence of that came from that study, Interact 2. Many places use labetalol infusions and GTN to continue that. An interesting study came out in New England Journal recently that says at the same time, don't push it too far, because actually if you start adding additional blood pressure lowering on top of that and you start dropping your systolic to below 120 during that first 24-hour period, you may actually be causing more harm than good. So it's getting that range of sort of 130 through to about 150 is what seems to be the sweet spot for that. There is research still going on into ischemic stroke and giving early blood pressure reduction. You may have heard of the Right 2 trial. This is actually about paramedics giving GTN patches in order to reduce high blood pressure before patients arrive at hospital, where there is a bit of evidence from previous studies that may be beneficial for reducing disability. It's a study. We'll have to see how that comes along. So forget I ever mentioned it. So oxygen saturations. Of course, if people are hypoxic, then they should receive supplemental oxygen. Hardly an earth-shattering recommendation, this one, but of course there was a lot of discussion some years back and a lot of work done by Christine Roth saying that actually oxygen may be beneficial in ischemic stroke, to give high oxygen or medium or even low oxygen supplementation to increase saturations would be a good thing to do. But actually the stroke oxygen study didn't actually support that, and it didn't show a reduction in disability as a result. So it's just used for people who are hypoxic. What do you do about temperature, glucose and hydration? Well, the best evidence we've got for this is actually from Sandy Middleton's QASC study in Australia, which showed that if you have rigid protocols in place, which are well adhered, lots of training, and you treat temperatures according to protocol, paracetamol, cooling, that you ensure that patients routinely have a swallow assessment, which we tend to do. One isn't necessarily done at that time in their control group. And you do manage people with hypoglycemia, even if they don't have diabetes, by using insulin infusions, you can get 15% reduction in death and disability. It's a hard area to gather evidence, but really for the recommendations, it clearly says swallow assessment, we should be doing that anyway. But patients with acute stroke should be treated to maintain a blood glucose concentration between 5 and 15 millimoles. And that they should have their hydration assessed with multiple methods to make sure they do maintain hydration. And there's a clear link in the national audit data between people with delayed intravenous therapy or nasogastric tubes being inserted and mortality. There's a clear link there, and we have to bear that in mind as being very important in the very early management of these patients. How do we measure hydration? This is a little plug, if you'll give me the liberty, bear with me. This is some work we did in our Trust on the Health Foundation grant, where we came up with a score to try and identify the people who, they had a safe swallow, but we didn't know how well they were going to drink because of difficulties lifting a cup up. They were on thickened fluids, and that's harder to drink. They had other health problems that meant it would be harder to drink. So this produced a risk score the nurses could use to determine how high risk they were with a matching protocol to give them assistance to drink. If you want to go and have a look for it, it's on the Health Organisation website, and it's appearing in the Nursing Times very soon, and can be used actually in a range of care of the elderly patients, but we developed it for stroke units. So thrombolysis, very quickly to finish off with, who knows what that red arrow is pointing at? Yep, that's a dense MCA. That white worm there is fresh clot sitting in the left middle cerebral artery in somebody who's having a stroke. And the reason I had the scan done is they've got a dense right hemiparesis and probably dysphagia. So we're going to give them thrombolysis. If we don't, or even if we do, actually potentially, there's a chance this will happen, and they'll have irreversible cerebral ischemia and disability as a result. What we're hoping will happen, that instead they'll just be left with little facial weakness like this patient was. And in fact, having instead of a large area infarction, they've just got a very small black area there. And about 30% of patients given thrombolysis will get some benefit from it, even if it's not a full recovery. Of course, the downside is that on average 3% may have a hemorrhage, which is bigger than the infarct they started off with, and so they neurologically deteriorate. The sort of thing that you'd need to detect so that you know whether they need to go back and have a scan done, have the infusion stopped, potentially be considered for neurosurgery or some sort of clotting intervention. And there are other complications with thrombolysis, of course, allergic reactions, bleeding outside of the brain, and you can spot all these by changes in blood pressure, pulse, responsiveness, and limb and movement speech difficulties. Various places have different ways of doing this. This is one I'm most familiar with. And what's important, I suppose, as features of all these sort of charts is that they note the time elapsed, a neurological score, and then an early warning score, potentially with thrombolysis thresholds indicated. Time lapse, of course, starts off at 15-minute intervals to begin with, then gradually reduces in intensity over the next 24 hours down to normal obs. Neurological score should reflect conscious level, and then maybe some focal aspects. Some places may be doing very regular NIH scores on our patients. That's fine if everyone's happy to do that and are confident they're all trained and understand what it means. And then it's useful to have the thresholds, like an early warning score, but specifically for thrombolysis on there. And on the back of this particular chart, it tells the staff what to do if there is an increase in blood pressure, a drop in blood pressure, a change in neurological status. So the important thing here is having something that everyone's happy with locally that is recording neurological status, blood pressure in particular, and telling people what to do in response to those. So, I told you that'd be quick. The basic care is very important. Local protocols that whatever you're using should reflect national clinical guidelines. Agree on what score you're all going to use locally and do training on that. Thrombolysis patients do require that bit of extra monitoring. And always think, is this neurological deterioration explained by modifiable physiological change? Is this something we can treat much more simply than actually what's going on in the brain? Or, in fact, is further brain imaging required? I'm just going to finish off with one more thing, which is a quick plug, forgive me. If any of you are involved in supporting research and you want to hear more about the CONVINCE trial, which I'll be setting up in the UK next year, then please come along on Wednesday to room 3 at 12:20. It's a drug study looking at whether colchicine can improve the rate of recurrent stroke and MI after stroke. Thank you very much.
Any questions at all? I have one around the neurological assessment and GCS. I'm also not a fan of it because of the lack of sensitivity with it. There's quite a few stroke-specific scales out there, apart from the NIHSS. Are there any others that you warm to at all?
I think what's important is that people are happy with what they're able to use and use it consistently, and that they also audit it. So, I think that something like the 5-point NIHS is quite reasonable, actually, combined with AVPU. But there is a lot of different scores and a lot of opinions out there. I'm not sure that really you can argue that one is that much greater than the other.
Of course, I'm never opinionated, but I have to throw in my 2 cents. We actually did a study called Slim Stroke Scales that's published in American Journal of Critical Care back in, I think it was 2013 it came out. What we showed was that if you do the full NIH on everybody, and you then subtract the different elements of these slim NIH stroke scales, that you have amazing problems even identifying that the patient has changed. Because you can have a negative, like a totally normal score when the patient actually has worsened. So what we've been encouraging our staff to do at the places where we practice is do your full NIH. And then that NIH is going to represent the findings for a certain vascular territory where the stroke is, right? So for example, if it's a PCA infarct, that patient should have a field cut, right? So instead of having to then every 15 minutes do another full NIH or a slim NIH that tells you to find words for what's this on my arm or can you lift your arm up or this kind of thing, just check the visual fields, because that's specific to the territory where the stroke is. So it's a lot more sensitive to picking up worsening within the territory that it's actually happening in, and it's super easy for the nurses. So think about that as you move forward, because I think it's the best possible option. And the GCS, of course, because the GCS will tell you that you have to select the best response, right? So if someone's right side is down but left side is functional and they can obey commands, you're going with the left functional side, and you can end up with a GCS of 15 when the patient actually has an NIH that's pretty severe. So we discourage use of the GCS unless it's a hemorrhage and we're doing an ICH score. That's just how we do it.
Thanks. Did that get published, Dan?
Yes.
Yeah.
American Journal of Critical Care.
Thank you. I mean, I think there's even like a 1-point NIHS abbreviated score. I think it's just facial weakness. Yeah, it's, you know, but I wouldn't recommend that, by the way.
Okay. Okay, and then we'd like Peter Lancorn to come and tell us all about preventing complications.
Thank you very much, Caroline. It's an honour to be invited, although, as it does, I do feel I've got the kind of knitted cardigan slot. It's the sort of familiar and predictable, but I hope I can persuade you after all this cutting-edge stuff that it's still very important. Actually, it fits in very well with the previous speakers. So anyway, I've been asked to talk about complications, and I think it just reflects the fact that stroke is a neurological condition, I'm told, but it affects real people. And when we're talking about complications, we're really talking about some of the commonest problems you'll see after stroke. I think it's hard to find a strict definition, but there are problems that are closely related to the stroke, but not necessarily a direct neurological consequence. Having said that, some of these definitions are a little indistinct. So, for instance, urinary incontinence can occur in people with an overwhelming neurological impairment, but it can also occur later because of, say, urinary tract infection. So the distinction's not always clear. And certainly in medicine, it's traditionally been a neglected area. Some of the sort of classic textbooks devoted hardly any page area to the problems of complications. Now, I was originally given the task of talking about the prevention of complications, but the more I thought about it, actually prevention, early detection and early treatment all tend to sort of smudge together. So it's hard to sort it out. So what I wanted to do was just to go over some of the important early complications, talking about specific aspects of prevention, early detection, early treatment. And this is a kind of reductionist approach, but at the end, I think I can't go 15 minutes without talking about stroke units. At the end, I'll bring it round to the kind of stroke unit message that really the systems we put in place are really important. The evidence base in this area is not fantastic, so I'll give a few opinionated practice points which you can disagree with at the end if you like. Thinking about the sort of classification of stroke, I think it's quite useful to think of them in categories. Neurological ones which relate most closely to the stroke pathology. This is just a reminder, the little asterisk, I've not to mention recurrent stroke, because that's coming next from someone who knows what they're talking about. The next category, which I think is arguably the most important in the post-acute phase, are the complications of immobility. And then there's sort of the comorbidities, there's cardiovascular problems and a whole range of other ones that I'll touch on briefly. We've already heard, I think, an important introduction to the problem of raised intracranial pressure. I'll just reiterate very briefly that it's caused by swelling around a large intracerebral hemorrhage or infarct. Basically, we have no effective non-surgical treatments, And I think our role, unless you're very handy with a Black & Decker drill, our role is really to identify the people early on who are running into real difficulties. And classically, the infarct people, I mean, that's the inclusion criteria for some of the trials, but it is more a problem of younger people who don't have cerebral atrophy and who've got big MCA territory infarcts or big hemorrhages. And the key thing, as Chris has mentioned very nicely, is monitoring the neurological score and conscious level. The occasions where I've seen this go wrong is where people have moved wards, and the folk, and especially moving wards on a Friday evening, and people haven't realised that things were changing fast and that you were moving into a different area. And I've certainly seen people who've lost the opportunity for surgery. Chris also mentioned early neurological deterioration, end or stroke progression. This is maybe a little of a more controversial area. I certainly think it does exist. And when it happens, it's associated with poorer longer-term recovery. And as Chris mentioned, it is closely linked to physiological problems, but there is this chicken and egg situation. The kind of belief system I work on is that there is potentially around an established infarct, there may potentially be some recoverable ischemic tissue, and we want to make the circumstances ideal for someone to recover from that. And Chris has already mentioned the importance of monitoring for physiological problems. I think in my experience, pyrexia is a really important one. Hypotension, you know, the frail elderly person found after a long lie at home, they're dehydrated, they're the ones you really worry about. People with bradycardia who've got some impairment of cerebral perfusion. So they're the things we're looking for. And I was trying to think, you know, what do we do actively? And actually, I think probably fluid management, making people aren't dehydrated and under-perfused, is probably the simple message. Evidence base isn't great for that, but for what it's worth, that's what I believe is important. Post-stroke seizures, not all that common, but will happen in a substantial minority in the first few days, and certainly the weeks and months after that, there'll be a lot more. Of course, again, it's an area where I don't know how you would prevent them, but the treatment is essentially drug therapy. But it's important to identify who are the people who are going to run into problems. And probably statistically, it's those who've got cortical problems. Hemorrhage is more common maybe than infarct. I think the important thing is, and this is like where nursing role is crucial, is that people may just actually behaving a bit oddly, be a bit vague if they've got complex partial seizures, they may be showing some odd repetitive behaviour. And so it's just to be alert to something strange going on so that you can actually get them assessed and for appropriate treatment quickly. Moving quickly on to cardiac complications, as far as I can see, these are essentially comorbidities. We're dealing with a population who are at high risk of cardiac disease, myocardial infarction, heart failure, arrhythmias, and particularly atrial fibrillation are common. In our experience, we do continuous monitoring in the first kind of 24 hours, but not after that. And I still think that the sort of monitoring the person's symptoms, their pulse, their blood pressure, if there's any concern, you know, get an ECG. It's not really rocket science. And I think that's probably the most practical way outside of the first 24 hours. And then moving on to complications of immobility, and this I think is one of the really big areas, and particularly infections and venous thromboembolism. Going on to infection first, why are they so important? Well, if you look at certainly the more disabled stroke patients, certainly a substantial minority will get an infection. If they get a chest infection, that's certainly associated with higher mortality. Both chest and urinary tract infections are associated with poorer outcome. Again, it's one of these chicken and egg situations, but I think we've got to assume that if there's something treatable there, we should treat it. And chest infections, I mean, this audience will be familiar that really the big risk factors seem to be dysphagia and immobility. So people who are not able to move about the bed and clear secretions properly. And this is where, the sort of careful positioning and handling, identifying swallowing problems, good management of feeding and fluids become really crucial. And we certainly have a very low threshold for checking for possibility of infection and starting antibiotics. And so the key points I would say here are, good positioning regimes, early swallow assessment and management. And this is where having stroke unit nursing staff is crucial, that confidence in managing people's feeding and checking for any change in temperature or oxygen saturation. The other big common infection is urinary tract, and depending on the age group you look at, up to 1 in 5 might develop this complication. Again, it's associated with the more disabling strokes. It's probably more common in women than in men. It is associated with catheterization, although whether that's cause and effect, again, is a bit uncertain. And the message is really, again, very similar, is to be thinking about the problem and anticipating it in those individuals. And this is probably, again, where good hydration, good fluid balance, trying to avoid catheterization. I put a very qualified early mobilization here. It is associated with bed rest and immobility, so logically you would think that would be a problem in the longer term. And again, just having a high index of suspicion and thinking about, good continence management. And also, as you'll be aware, many of these patients will just become a bit more tired, a bit less well, doing less well than they were yesterday, maybe complaining of vague symptoms, and just to be thinking about infection in this group. If I'm making such a big play of infections, why don't we just put everyone on antibiotics? Well, in fact, there's 2 very big trials come out from the UK and the Netherlands, and I've just added them to 6 previous smaller trials. These are trials of giving everyone with disabling stroke antibiotic therapy. And to cut a long story short, you can reduce infections, actually clinical infections, but there was no measurable impact on death or disability or a whole range of other functional outcomes. It appeared to be, the various regimes that are being used appear to be relatively safe. And I take it, the message from all these trials is that we should not be using antibiotics prophylactically, but if you really suspect someone's got a chest infection or a symptomatic urinary tract infection, then go ahead and treat them with appropriate antibiotics. A couple of other problems of immobility, pressure sores, fortunately, mercifully, not as rare to have as severe as this. This is someone who had a very long lie at home. But, you know, depending on what patient group you look at and how you define the pressure sores you can get, you know, they still exist, and they are associated, as you would expect, with stroke severity and with frailty. I haven't put any practice points here because I'm assuming this audience will know much more about this than I do, but there's nothing particularly special about the management of stroke-related pressure sores. It's a high-quality management of pressure sores, full stop. Similarly with falls, I'm not sure that there's a specific stroke fall lesson to take. It's very common in both within hospital and after people go home with stroke. The risk factors are very similar. Indeed, many of us would argue that if you've got no falls, you're probably being overcautious, although I don't know a unit that has no falls. But, you know, the sort of standard multidisciplinary approach of, you know, physiotherapy, removing toxic medications and having a safe environment, whether it be the home or the hospital, remain the mainstay of our approach. And then the last of the complications of immobility, of course, is the venous thromboembolism. And we're familiar with the CLOTS 3 trial. It was published quite recently. To cut a long story short, we've got a lot of interventions have been tested to prevent venous thromboembolism. The approach I take is, if it's a milder ischemic stroke, well, actually aspirin does have some preventive effect. If it's someone who's immobile, then we should be thinking about intermittent pneumatic compression. There are things I believe are a good idea, like avoiding bed rest, good hydration again. And the question around anticoagulation is really a trade-off. Is this person at more risk from venous thromboembolism than from anticoagulant-related hemorrhage? And again, you know, that the key thing is to be thinking about this as a problem and be aware that somebody who's managing less well is developing new symptoms. This might be at risk. And then finally, I don't have time to go into all the sort of later post-stroke complications, but you'd be familiar with all the other ones: depression, anxiety, emotionalism, pain, fatigue, which are all now getting researched much more. I think in general these are more a problem of slightly further down the patient journey, but just to mention them for completeness. So just to sort of round off, I think I've gone through a number of familiar complications, really taking them as individual problems. However, I do think that one of the real developments in my career has been the move towards organised inpatient stroke unit care. And I think, again, I don't have trials to prove this other than ones like the Middleton study in Australia. But what I think has happened as staff, particularly nursing staff, have become more skilled and confident, both in identifying problems, preventing them, and communicating with their colleagues, then so we've managed to prevent complications and also identify ones that occur more quickly and get treatments implemented quickly. And just out of interest, if you take the list of complications I've alluded to in the last few minutes, and take some of the scales that Chris Price and I have mentioned, and in fact, most of them, I've just given my sort of back of an envelope estimate of how useful they are. You know, most of them actually map across very well. So our sort of routine observations aren't just done for the hell of it. They actually have some purpose there, and they do serve as a sort of early warning system for a whole range of different common complications. And similarly, when Alex Pollock and myself surveyed the stroke unit trialists about 15 years ago, they came up with a list of things they thought they were doing in acute stroke patients. And it's astonishing when you look at, with the prism of complications, look at just how many of these are probably important. So, you know, swallowing assessment, fluid balance, good management of feeding, IV fluids if you're nil by mouth, low threshold for antibiotics, good positioning on handling, trying to avoid urinary catheters. These were things that, if you like, the early stroke unit adopters were saying many years ago, and I think it's really fascinating to see how it maps into the story of preventing complications. So just to finish, I think complications can be a major barrier. It's particularly a problem in the older people with more severe stroke. And I think the key thing is that we have within our stroke units the sort of processes of care that minimise the risk of complications and identify them early when they're happening. And although the evidence base for specific treatments is often limited, if you look at the changes that have happened over the years, I think there's little doubt that this has been a really crucial role of specialist stroke nursing in improving the outcome of stroke patients. So with that, I'll say thank you very much.
Okay. Has anybody got one quick question? We're getting a little bit late. No, okay. I think you've got off lightly. We'll move swiftly on to Gavin then, who's doing 17 and a half minutes.
Is this working? Right, a quick romp through secondary prevention. Secondary prevention, obviously preventing strokes after a TIA or a stroke, so we're not really going to talk about primary prevention. And these are the standard secondary prevention conditions that we're going to be looking at. No surprises there, I don't think. So the problem, well, we all know that the first stroke is a problem, so about half stroke survivors, half stroke patients will survive about 5 years, half won't. A third will remain disabled, 1 in 7 in permanent institutional care. So a big problem having a first stroke. Having a second one isn't good news either, though, and this is one of the main risk factors for problems after a second stroke. Poor long-term outcome is predicted by subsequent strokes. So preventing strokes as the first event after a TIA is a great idea, but also preventing strokes in people who already had them is clearly going to be helpful. When should we do it? Well, this is data that is from the Oxford study, which, as you know, collects, if you know about Stroke Community Project in Oxford, has been collecting data for many years now, and we know from that data that it's really early on that these problems occur. Really in the first few hours and the first few days after a TIA or a stroke is the highest risk. So we should be starting really early. And in the case of TIA patients, we should be starting straight away. Stroke, it gets a little bit more complicated. In big strokes, we don't like anticoagulating patients straight off, so warfarin we may delay. Hypertension, Chris has already mentioned that we're a bit uncertain about when to start dropping blood pressure. So there are some uncertainties about when to start. There's even more uncertainty about when to stop. Nobody's really looked at this in great detail. We carry on these secondary prevention strategies lifelong once somebody has a stroke, and there is a little bit of interest beginning to be looked into whether or not some of these treatments could be stopped safely. But at the moment, it's a lifelong trip for the patient. So who might benefit from secondary prevention? The abbreviations, ischemic stroke is IS and intracerebral hemorrhage, PICH. So blood pressure, basically most people will benefit from blood pressure reduction. Warfarin, the majority who've had a TIA and an ischemic stroke, but obviously not those with a hemorrhagic stroke. Carotid endarterectomy, it's quite a small number, although the absolute benefit for that small number of patients is sizable. Lipid lowering, ischemic strokes and TIAs definitely. There's a bit of debate about hemorrhage patients. There's a little bit of evidence that if you've had a hemorrhage, going onto a statin might not be a good idea. Antiplatelet drugs, again, we can find to ischemic events, TIAs and strokes. And lifestyle modification, which usually is treated as the sort of last, but it should really be the first part of all of this, that is beneficial to everyone. So this is the plot of your systolic blood pressure against your stroke risk. And it's fairly easy to see that looks like a straight line. And this concept of hypertension, I've got high blood pressure, treat it, isn't really correct. Blood pressure can be seen as a risk factor. The higher it is, the higher your risk. The lower it is, the lower your risk. And the obvious suggestion will be to lower blood pressure. What does that do, or what does that mean? Well, if your blood pressure is more than 115/70, so quite a lowish blood pressure, then your cardiovascular risk increases quite significantly, with increases, as you can see, doubling for every 20 in systolic pressure. Conversely, if you can lower blood pressure, so a 10 millimeter reduction isn't too high, that is achievable with blood pressure drugs, you can reduce risk by about 27%. And the target is much debated, and there's much talk about it, and there's been a lot of interest over the last few years in worries about low blood pressure, over-lowering of blood pressure, in particularly in elderly patients. Could we be causing more harm than good? The jury's still a little bit out on this one, but at the moment the guidelines and the most recent update of the RCP guidelines suggests a target of under 130/80. If you want to choose a drug, then the calcium channel blockers, amlodipine being perhaps the prime example, is the drug of choice. Beta blockers, perhaps a bit less effective in stroke or for cardiac patients. Atrial fibrillation, very important risk factor. Risk of recurrent stroke is quite high for an individual who's had a TIA or a stroke, 12% per year. And up until recently, warfarin was the standard therapy to reduce risk. And you can reduce risk by about 2/3, down to 4%, so an 8% absolute risk reduction for those patients. So quite a sizable risk reduction. But unfortunately, we do cause some bleeding, about 2% excess bleeding risk in these patients. So overall, we can stop about 80 strokes for every 1,000 patients we treat per year. But we will cause 20 serious bleeding events. So there is a downside to anticoagulating patients. And in terms of the target INR, less than 2 doesn't seem to work. Over 5 is quite risky, and 2 to 4 seems to be the sweet spot, the usual target range, 2 to 3, and 2.5 being where patients should aim for. We've got some new drugs on the block. These are all the new oral anticoagulant drugs that don't require monitoring. They have a few advantages. They work very quickly, so in the past, when we saw somebody in the TIA clinic, we might have to put them on heparin and load them with warfarin. It would take months to get them to an adequate INR, and then you stop the heparin. These drugs work very quickly, so it's great in the clinics now. We can start patients, and we'll know that within a few hours the drug will be active. Very few interactions, unlike warfarin. Warfarin tends to interact with most things, and you don't need to do the blood testing, apparently. What about the drawbacks? Well, we have an antidote for warfarin, but we don't have an antidote for all of these drugs. We now have one for dabigatran, which is unpronounceable. But there are 2 other drugs, the rivaroxaban and the apixaban. There is an antidote, but it's not yet been approved. So we will have drugs that can very quickly reverse the effects of these novel anticoagulants quite soon. It's a twice daily dosing schedule, which might be a bit of a pain for patients who are used to once a day with warfarin. And of course, the great thing about warfarin monitoring is at least you know if the patient's taking it. So by measuring the INR, we know that the patient must be on the drug, whereas there will be a possibility that patients might say that they're on the drug when they're not. So we might have more trouble detecting poor compliance with these new drugs. And of course, the cost. This is just the standard drug cost. There is a benefit, of course. If you don't use warfarin, then you don't need an anticoagulation clinic. But of course, as long as there's one patient taking warfarin, you'll need your monitoring. So until everybody's off, we need to keep the monitoring. So you don't actually save that much at the moment, although hopefully that will come through in the long run. There's another kind of AF, though. We got the continuous sustained atrial fibrillation. But what about paroxysmal atrial fibrillation? These are patients who don't have it when they come in necessarily, but have little bursts or bouts of atrial fibrillation. How do you detect those? Well, it if you look really hard, you can pick it up in quite a sizable proportion, about 1 in 8 patients maybe. But it depends how hard you look and what tests you use to do that. So there are different mechanisms. Single admission ECG will pick it up in about 8% of patients. But if you go with the whole hog, and go for cardiac implantable loop recording, you can get maybe up to 17, 20% of patients you'll pick up. And the question is, how far do you go and which patients do you go down that route for? There's a little bit of a suggestion that you can target this towards patients who have particular kinds of strokes. Strokes in multiple territories or involving the cortex rather than the deep parts of the brain. Carotid disease, big part of prevention. One of the big pluses of a TIA clinic is to try and pick up patients who have carotid disease so we can take away the embolic source that's throwing off bits of debris into the brain. We've got to look at the carotids. We have different ways of doing that. So we've got to image the patient. This is a duplex ultrasound. It's called duplex because there are 2 bits to it. There's the image, which is pretty rubbish usually, and there's the flow data, which is what we use to work out the degree of stenosis. And ultrasound is cheap, and it's readily available usually, and it's probably the best screening test. Then we have other imaging modalities. You might be familiar with CT angiography. This is a rather pretty one where they've kept the bones in and done a very nice picture. I don't really like those because you can't see the arteries, but some radiographers like doing them. And this is the MR angiogram, which has some advantages. It doesn't involve ionizing radiation. And calcium doesn't show up on the MR angiogram. But some combination of these, the guidelines suggest doing an ultrasound screen followed by a second modality to confirm the degree of stenosis. And you probably have different ones that you do in your own units. Question is, which patients should we be doing these tests on? And this comes back to the first talk that we had. Of course, we want to be doing it in patients who've had carotid symptoms. And that's a quick overview of the first talk. So dysphasia, monocular visual loss, one eye, visual disturbances, complicated cortical problems that relate to the MCA territory. These are all carotid events. Whereas the back part of the brain, the occipital lobe, the brainstem, the cerebellum, different symptoms, and you'll be familiar with those from earlier on this afternoon, so I won't go through all of those. There is the group in the middle, which can be both. So if you have lacunar infarcts, small deep infarcts in the brain, they're not likely to have been embolic from the carotid artery. They're more likely to be a small artery blocking off in the brain. You don't necessarily want to send somebody for a risky operation if the problem is related to the small blood vessels. But sadly, you can't really tell from the symptoms alone, and so a lot of patients who probably have had small vessel events will end up going for surgery. If in doubt, we tend to do that. So how does carotid stenosis surgery match up in the prevention world? Well, the risk, first of all, is highly variable. We've got quite a sizable variation in risk. If you've got a mild stenosis, the risk is quite small, about 7% over 3 years. That's far less than the surgical risk. So we obviously don't operate on mild stenosis. Tight stenosis, 27% is the average, but within that, there's a whole lot of different patients hiding. There are some patients at very low risk, even with a very tight symptomatic stenosis. And there are other patients with huge risks. Another way to think of that is with this statistic, the number needed to treat. It's quite a good statistical term for patients. It's the number of people that would need to have a procedure or a treatment before one person would benefit. In this case, it's over 5 years. So this just tells you a little bit about the different variations within that risk. So firstly, carotid surgery isn't so good for women as it is for men. Various reasons why that is. But you need to treat 9 men to prevent 1 stroke over 5 years. You need to operate on 36 women to prevent 1 stroke. Health economists, close your eyes. Number needed to treat if you're elderly is quite small because elderly patients tend to have a high risk of recurrence. If you're young, the risk is smaller, and so the number needed to treat is higher. That's because your risk of recurrence is already a bit reduced because you're young. Timing plays a huge part, and this has been a big push in the last few years. You'll be aware of emergency clinics over the weekend to try and see patients so we can get the vascular surgeon to see them straight away, and they can put them on the list for 3 weeks on Tuesday. The number needed to treat in less than 2 weeks from the symptoms is about 5. If you wait to 12 weeks, then you're up at 125 operations to prevent 1 stroke. Clearly not economically sound. When I was training here in Liverpool 20 years ago, most of our patients were being operated on after 3 months. So most of the surgery that was going on when I was a trainee was a waste of time, I think. 50 to 70% stenosis, this is still tight stenosis. No evidence of benefit in women at all, and little benefit for either sex if you delay for more than a couple of weeks. So time is a critical factor with carotid disease, and this is just a slide to show that again. So this red line is the surgical group. They have a high surgical complication rate, which starts them off there, but then it goes pretty flat afterwards. Medical risk, high to begin with, but then drops off, and certainly by 2 years, it's about the same. So carotid plaques that are dangerous and throwing off bits of debris seem to stabilize after a couple of years. And if you're going to operate, you should be operating early when the risks are much higher than the medical risks. To try and make sense of all the complicated different bits and bobs that go on with carotid disease, we now have risk calculators. So these take account, this is an online one that you can use to take account of all the different risk factors, plug them into a computer model, and throw out the 5-year risk for you. You can work out whether it's more or less risky than the surgery. And there are picture charts if you haven't got access to a computer. And so you can calculate an individual's risk rather than just quoting them a figure for everybody. Lipids. Pretty similar to the blood pressure graph, actually. If you lower nasty cholesterol, LDL cholesterol, low density lipoprotein cholesterol, then you get a pretty linear fit with reducing the risk of major vascular events. So for each 1 millimole reduction in LDL cholesterol, you get quite sizable relative risk reductions in both strokes and heart attacks and other vascular events. The absolute benefit's quite small, though. So statins and lipid-lowering treatments will lower your relative risk sizably, but the absolute risk reduction tends to be quite small, which gives us quite big number needed to treat. So 45 folk that you need to put on a statin for one person to be prevented from having a stroke over 5 years. We all worry about serious side effects and complications from these drugs. The really nasty side effect is where your muscles necrose and become inflamed. And that happens less than 0.01% over 5 years, so it's a very, very small risk. Patients report much more in the way of side effects with statins, probably because in part we suggest that they're going to get side effects. There is a little bit of evidence that that's part of the reason for the side effect profile being poor with statins. What's the target? Big debate about this, but in the current guideline, we've opted for the NICE target, which is a 40% or more reduction in the non-HDL. That's slang for LDL. It's very hard to measure LDL cholesterol, so it's the non-HDL aspect of cholesterol. One of the other big drugs that we use, as well as statins and blood pressure drugs, is antiplatelet drugs. Some good work just this year, you might have heard of it on the radio and the morning shows. Much higher benefit than we thought for aspirin in the very early stages. So if you give aspirin after a TI or a stroke, you can reduce risks by 60 to 70% in the first 6 weeks. That translates into 36 fewer events per 1,000 over about a 2.5-year period. That's the number needed to treat. It's about 5 to prevent any vascular event over 15 over a 5-year period. Which drug should you use? Well, it changes every few years, but the current flavour is clopidogrel, 75 milligrams daily. That's equivalent to the one that we used to use a few years ago, aspirin plus dipyridamole. Dipyridamole, rather indigestible, causes headaches and stomach aches, so we tend to not to use that anymore. Best to avoid the combination. Heart doctors like it, but it does cause an increased bleeding risk. There's some interest in using it short-term up front after a TIA or after a minor stroke, but at the moment we still don't recommend that in the guidelines. And best to avoid combining with warfarin or other anticoagulants unless you're a cardiologist and you've got to just put a stent in that requires these drugs. Last slide, I think. Lifestyle. Stop smoking, 35% relative risk reduction, quite a big risk reduction. And they get back to background risks after about 5 years. Regular exercise, again, sizable risk reductions. These are based on coronary populations, so we're assuming it translates. Moderate alcohol intake, it's been reduced a bit, 2 units per day for men and women now, but again, sizable risk reductions. Healthy diet, we have no idea what benefit that does, but it's obviously recommended. and weight and restricted salt intake. And I've fibbed, there are 2 more slides, but they're very quick. What could we possibly do if we put all these things together? Well, the calculation is we should be able to reduce events by about 80%. And hey presto, this is the Oxvasc study again. This is with delayed standard management. This is with immediate management. And we get about an 80% reduction. So it works, giving prevention drugs stops strokes. Got to get the diagnosis right and use these slides with judgment. That's the references if you wish, and I'm sure these slides can be available if anybody wants them. I'm happy for them to be sent out.
Okay, thank you. If we can just move on to Colette, sorry, because I know we're going to get kicked out of this room. So if Colette could just, come and just do a couple of minutes on this and then.
Hi everyone, I'm Colette Miller. I've been working with Caroline in redeveloping the Stroke Specific Education Framework website over the past few years, and if anyone's ever used it in the past but hasn't used it recently, then hopefully it's a lot more user friendly than it used to be. I'm going to cover creating your personal role profile and updating your knowledge and skills following a training event. If you need to do either of those, there are handouts here at the front, so if you do want to grab those, you don't need to be making notes now at all, okay? So, do I need to press it very, very, very hard? Okay. If you are yet to register for an account, I'm pretty sure that everyone in the room has one, obviously, but if you don't yet, then I'll briefly show you how easy it is to set up. Obviously, Caroline explained earlier what they're for. So all you need to do is go to the Stroke Specific Education Framework website, and then you enter your email address, confirm your email address, enter a code, and you will receive a password. Okay, that password will be displayed on screen, and you can either copy and paste it there and then, but it will also be emailed to you. We have noticed there's been some issues with crossing NHS firewalls, so if you don't get your email, if you send an email to the SSEF Enquiries website, we'll be able to send you a password personally. Okay, and so then you need to sign in, and you will again just enter your email, password, and enter a code. And once you've signed in, you're taken to the SSEF user dashboard. So this area is called the dashboard, but you need to tell the system what you are, who you are, what grade you are, etc. So you need to click on define your role and band, and you will see this page. It's quite easy. I'm hoping everyone thinks this looks quite easy. Is there anyone who thinks it looks really difficult? No? Fabulous. So you enter in your role, your grade, and then these are the standardised role profiles we have at the moment. If you can't see your role there, we are in the process of creating more role profiles, and if you would like to help us, that would be even better. So come along and see us at the stand and we can get you to help. We are in the process of doing a paramedic role profile as well at the moment. And then once you've created your profile, you've defined the system, you've told them who you are, what you need to know, then you can start defining your knowledge and skills. So it's a bit like SurveyMonkey. You just click on element 1, and then there's a few statements, and you answer whether or not you think you know, and then it will move you on. You can do this at any time. You can stop. The system automatically remembers where you're up to. It usually takes people between 20 and 45 minutes to do, depending on how quickly you read, okay? Then, the next bit, this is the important bit. If you want to add a training event to your role profile, you sign in, again, quite simply, using your username and password. But if you can see here at the bottom, there's a review a course section, okay? Course providers should give you the unique course review code, and that will enable you to then add the knowledge and skills that you receive on any training event to your profile. So the course code for this workshop is there, displayed up on the screen, and the course code for the actual conference itself is also displayed on the screen. So you can add both of those to your role profile. The way that you do this is you enter the code in that box at the bottom, and then it takes you through to an area where you submit a review. So we ask something from you before you can actually add the knowledge and skills. You give a star rating for the course, and then you enter a comment, and then you'll be able to add the knowledge and skills. The system automatically updates your profile with the knowledge and skills that have been delivered during the training event. And if you have any questions at all about that, then please come and see us. We're in SEF's Stand F downstairs. And we also have throughout the next 2 days, there are sessions where you can come and SEF yourself. We have iPads and you can sit there and we will be able to help you whilst you do this. Thank you very much.
Thank you very much for coming this afternoon. We do hope you'll join us with registering yourself on the SSEF. And thank you very much to all our speakers who've done a very fabulous job this afternoon, and have a lovely conference.